Hello, everyone. My name is Kay Gooch, and I'm Director of Community Programs here at ARC. I'd like to welcome you to our May webinar on understanding more about living with amyloidosis, and I'll introduce our speaker in just a moment. Sabrina, if you could maybe take us to the slides, be great.
There we go.
There we go. Wonderful. Thank you. If you could move to our second slide. I'd like now to just give you a brief overview on ARC. ARC is a patient-driven organization that's dedicated to improving the lives of patients with amyloidosis through education and support and accelerating cutting-edge research. We have 4 focus areas, as you can see here. One is, of course, improving the speed and accuracy of diagnosis. The second is also understanding the disease, increasing our understanding of the disease to identify new treatments, and then accelerating improvement and reimbursement of effective treatments. And then the last is enhancing the care and quality of life for patients and care partners. So certainly feel free to reach out to ARC or look at our website if you'd like to learn more about us. So on our next slide, I'd like to just take this moment to thank our generous sponsors who are listed here today for your support of our webinar series. We appreciate your support. And then just a little bit more before we begin, the webinar is being recorded today. So we will have this available on our website. So if you'd like to view it again, it will be available. We'll send out a link to it in a follow-up email. And also just a reminder to submit your questions at any time during the presentation via the Q&A chat box. There's a box in there for Q&A, so just feel free to do that. We'll have our question and answer time at the end. And if you're having any trouble with the audio, if you're using your computer, you can always dial in on your phone. So now I'd like to take a moment to introduce you to today's presenter, who is ARC's Senior Research Manager, Sabrina Rebello. Sabrina is a seasoned expert with over a decade of experience in capturing real-world evidence and patient-reported outcomes. With a strong commitment to amplifying patient voices, Sabrina has dedicated the last 5 years as the Senior Research Manager here at ARC. Sabrina leads on community research initiatives and data generation efforts aimed at enhancing patient support and improving health outcomes. She is passionate about fostering collaboration and empowering patients, and works tirelessly to ensure that the needs and experiences of those affected by amyloidosis are at the forefront of our research and advocacy efforts. So at this time, I will turn it over to Sabrina. Thanks, Sabrina.
Great. Thank you, Kay and ARC, for the opportunity to be speaking today on insights from the annual community survey. Our focus is understanding what it's like to live with amyloidosis straight from community voices. Here's our agenda. So why this research matters, what we've learned from both caregivers and patients, and what the next steps might be. So why research matters. Patient-reported data uncovers real-world needs. It guides treatment priorities and drives policy change. Individuals have access to collective knowledge that can inform their own personal health journeys. It fosters a sense of empowerment, promotes informed decision-making, and helps build a supportive community. So what is our annual survey? So this annual online survey asks about diagnosis experiences, treatment journeys, and quality of life impacts. We do this annually, and I've done this for the past 3 years, starting in 2022, with the most recent one done last November. So how do we use our annual survey? So we leverage your responses to inform clinicians, researchers, advocacy efforts, and support services. Key insights from the survey are made accessible through multiple channels, including peer-reviewed publications, scientific events, patient group discussions, and an online summary of the ARC website. You can visit our website for a summary of the 2022 and 2023 results. This 2024 results summary will be available later this year, and I will be incorporating what we've learned from all 3 surveys from 2022 to 2024 during today's presentation. So what patients told us? From our most recent survey, we had 867 patients globally share their experiences with amyloidosis. About 90% of respondents were from North America, mostly Canada and the US. Breaking it down by amyloidosis subtype, across the 3 surveys, TTR wild type amyloidosis is now the most commonly reported subtype. And looking just at AL amyloidosis over the years, here's what respondents have shared. So of AL respondents, the majority were aged about 50 to 70 with a slight male predominance. The average time from when symptoms started to initial diagnosis with AL amyloidosis has decreased from 2.7 years to 1.4 years among those recently diagnosed. So this was defined as within 18 months or a year and a half of each survey. The 5 most common early symptoms reported are shown here, with fatigue and shortness of breath being the most common. The number of diagnoses being made at specialized amyloidosis centers compared to non-specialized centers remains the same among those with AL amyloidosis, and the diagnosing physician is most commonly a hematologist-oncologist. Starting in the 2023 survey, we began asking about current symptom severity, and then last year in 2024, we also added a question about overall health of patients. The majority of respondents reported moderate or better symptoms, and their health either good or better. So we asked patients what they feel about their current treatment. So for patients that reported to be currently using daratumumab or Darilex, the average rating was moderate satisfaction as to how well daratumumab managed the disease, relieved symptoms, and overall treatment satisfaction. Across the 2023 and 2024, most respondents felt the treatment was effective in slowing or stopping disease progression, with a notable 2024 increase in symptom relief reports, and there has been a decline in the uncertainty about treatment impact. We asked respondents to rank what matters most in treatment outcomes starting in the 2023 survey, and living longer topped that list, followed by improvements in physical function, symptoms, ability to participate or engage with family or friends, or to engage in work, and also the improvement in the ability to perform daily activities. Patient priorities for safety, access, and convenience had safety being the highest prioritized, followed by affordability, having more than one treatment option, frequency of administration, and the ability to self-administer the treatment. We also asked for patient feedback on their ongoing care, and we are seeing more care delivered outside of those specialty centers. Satisfaction and confidence in their care is high. However, more information on support groups or other support services is needed. Next, insights from the TTR amyloidosis group, including both hereditary and wild type. For TTR wild type amyloidosis, predominantly male and white, we are seeing a slight increase in the number of women being diagnosed. So it went from 7% to 9.5% in the most recent survey. For hereditary TTR amyloidosis, about 80% white, and the gender split is far more balanced. For the pathway to diagnosis, we are seeing that diagnosis delays remain a challenge. The time to diagnosis from when symptoms onset began to when they were actually diagnosed varied quite a bit. So it went from 5 to 3 back to 5 amongst hereditary TTR amyloidosis. And then similarly for wild type ATTR went from 4 to 2.5 to 3.5. We did see that carpal tunnel syndrome is increasingly reported as an early symptom or medical condition. Fewer diagnoses at a specialized center, especially for TTR wild type, have been seen, and the diagnoses were often made by cardiologist for wild type and neurologist for hereditary. 45% of hereditary TTR and 34% of wild type report fair or poor overall health, and up to 30% report mild or no symptoms. So we asked patients how they felt about their current treatment. So this included all of the 5 treatments that had been approved prior to the last survey. So this does not include ATTRv or acoramidis, as well as the expanded indication for vutrisiran or Amvuttra. So tafamidis or Vyndaqel or Vyndamax has the most users, so this was over 800 users, though many of them were unsure of its impact on amyloidosis. Vutrisiran and Amvuttra scores slightly better with stopping progression and symptom relief. And sample sizes were pretty small for eplontersen or Wainua and intertersen or Tegsedi, making the apparent benefits less generalizable. So for context, we're talking about dozens of patients as opposed to hundreds for the other treatments. Overall, patient satisfaction was moderate, especially for disease management, and less so for symptom relief. And all in all, they were all pretty similar as to how patients felt about those treatments. So first, looking at the goals of treatment from the hereditary TTR amyloidosis patient perspective. So this was very consistent with what we saw with AL. So living longer, physical function, symptom relief, and life engagement were pretty important. And affordability is the most important factor in treatment access and convenience. And now from the wild type TTR amyloidosis perspective, so very similar to what we just saw. So living longer, physical function, symptom relief, life engagement were pretty important, as affordability was the most important factor in treatment access and convenience. For TTR amyloidosis patients on their ongoing care, there was an increased trend toward non-specialized care again. Similar satisfaction trends as we saw in AL, so about 90% rate their provider knowledge pretty highly, and only about less than 50% satisfied with the support service information that they are provided. So much of today's presentation focused on AL and TTR amyloidosis, reflecting the largest groups in our community. We also want to acknowledge and highlight the voices of those living with the less common subtypes, such as AA, ALECT2, and hereditary forms beyond TTR. Over the past 3 years, individuals from these rarer subtypes have generously participated in our surveys. We've had pretty consistent responses over the past 3 years, and they're sharing their stories and their experiences. And even though it's a smaller number, their insights are very deeply valuable. We are committed to learning more about their unique journeys so we can better understand, represent, and serve the full spectrum of the amyloidosis community. And in this section, I'll share what we've learned so far from these participants, from their demographics, diagnostic pathways, and perspectives on care, to begin shedding more light on their experiences and to ensure that their voices are heard. Their demographics, they're predominantly white and female. The pathway to diagnosis varies wildly year to year. So for the symptom onset to diagnosis, went from 2 to 8 to 4, and the diagnosing physician was everywhere from cardiology, gastroenterology, nephrology, or hematology oncology. Looking at their current symptom and current health, most report moderate or better symptoms and good or better health. And for their feedback on ongoing care, we did see a significant decline in perceived provider expertise. So this went from 80% to less than 60% by 2024, and less than 40% rated support service information highly. So the message here is that these patients are feeling less supported, and their care is often fragmented or delayed, and more attention is needed to close these gaps. So what caregivers told us, beginning in 2023, the survey shifted to directly assess how caregiving affects informal caregivers. So these are mostly family members who are stepping in to help a loved one, so a spouse, a child, a parent. Over 500 caregivers have participated from 2022 to 2024, with about 80% living in the US. Amongst amyloidosis caregivers, work-life balance can be strained. The percentage of caregivers reporting job-related changes rose from 44% in 2023 to 55% in 2024. And most of the common changes that had to be implemented were reducing their work hours, switching to flexible work, or even retiring early. Caregivers are largely filling emotional and practical support roles for their loved ones. 70% of caregivers are providing emotional support. About 50% are providing help with transportation, meal preparation, and scheduling of medical care. So looking at the emotional impact on amyloidosis caregivers. So while most caregivers report low to no distress, that percentage is declining. So it went from 78% in 2023 to 65% in 2024. Moderate distress doubled from 12 to 24%, and serious distress remains steady, about 10 to 11%, signaling a consistently vulnerable subgroup. And so the implication of this is that mental health stress is growing and needs attention. So to assess what the actual caregiver burden is, there's a measure called the Zaret Burden Interview. So this is 12 questions asking about different elements of caregiving burden and providing an overall scale or score. So we found a high and persistent caregiver burden among amyloidosis caregivers. More than 40% of caregivers reported high burden in both years. Mild to moderate burden slightly increased from 38% to 41%, and the low burden is rare, only about 20% reporting a low burden, and that number was declining between the 2 years. The most burdensome aspects reported were difficulty balancing care with work or family, loss of personal time and social life, and the emotional strain from wishing that they could do more for their loved one and feeling out of control of their own lives. So what are the overall implications of this? Caregivers of amyloidosis patients face emotional, practical, and economic strain. There is an urgent need for respite and support services, mental health care, and policies to support working caregivers, and continued tracking will help target interventions where they might be needed most. So what do all of these results mean? From the patient perspective, patients want care that reflects what matters most to them. So longevity, function, affordability, and feeling safe. We also need faster diagnoses, better non-specialist support, broader treatment access, and more inclusion for the rarer subtypes. For caregivers, the message was pretty clear. They need mental health care, respite services, and flexible policies, and ongoing tracking can help us tailor solutions where they might be needed most. So what comes next? How are we going to turn your voices into action? So some of the steps that we can take are educating doctors to speed diagnosis, empowering local providers, expanding expert access, advocating for the rarer subtypes, and building strong mental health and caregiving support systems. Thank you all for being part of this vital work. Your participation in ARC's research is shaping a future where patients and caregivers are better supported, better informed, and better cared for. Thank you.
Thanks so much, Sabrina. We have a few questions here, but I just wanted to remind everyone if they'd like to put their questions in the Q&A and get to those. And also that, again, this is being recorded and the slides will be available as well. So Sabrina, we have a question for someone who said they may have missed this at the beginning, but how was your sample chosen and the percent respondents? And do you kind of know how that compares with the general amyloidosis population?
So the patients and caregivers are largely from the ARC mailing list, so who subscribes to our newsletter. It's also shared by the amyloidosis support groups, and some of the other international associations have agreed to share the survey as well on their social media or through their email. In terms of the percentage of respondents, I'd say it's probably about 20%. And I do not believe that this is necessarily reflective of the amyloidosis community at large. I think that we have a very dedicated community that loves to participate in research and wants to find out more and wants to help out more. And that especially with some of the other subtypes, the rarer subtypes, they might not feel empowered enough and might not be participating in our surveys and with ARC in general.
Thanks, Sabrina. And someone else just wondered if you could just reiterate again the survey participant breakdown.
In terms of patients and caregivers?
Yes, and if you have, I think they're asking also like the different types, if you.
So it's about 85% patients to 15% caregivers. So we have roughly about 900 to 1,000 patients who participate. And then this was some of the subtype breakdown from our most recent survey, which is reflective of past surveys as well. So TTR together with hereditary and wild type makes up about half of patients, and then AL is about a third, and then about 25% are some of the other subtypes.
Great, thanks. So what was the single most surprising finding from the survey, Sabrina? If you had to say that, what would you think?
Um, Honestly, it's the sheer number of other conditions or kind of all of the hurdles that patients have to go to ultimately get their diagnosis. Um, like it's hard to see in the numbers and like the delay necessarily from symptom onset to when they were diagnosed. But in some of the where we allow respondents to provide more of a story and explain more of what their actual journey was, just just get constantly getting dismissed like, oh, it's just like you're getting a little bit older, or oh, it might be related to your arthritis or something like this, and they're just constantly dismissed and they're constantly having to fight to get more tests to investigate more that it's not just aging, that there's something else going on. Like it is surprising because like we've been kind of working under this kind of like academic or research bubble where like, oh, there's been increased disease awareness. Like now we have all of these treatments that are available. So obviously more and more people know about it, but like it's still a struggle for most patients to be able to get that diagnosis and to start their initial treatment.
Serena, someone was asking if you are able to determine if the same respondents are returning year after year.
I would say, I don't know for sure, but I'd say probably 3/4 are probably the same, but we do get at least a quarter of patients are new to each year.
And Serena, that might kind of be a follow-up question around, sort of how people can help maybe disperse this survey next year or kind of help when we are, I guess later on this year, like, are there ways that we're thinking about changing that or doing that, or how can people help with that?
Great. So we are planning on launching the 2025 survey early this fall. So hopefully September, early October. So if you're signed up for the newsletter on our mailing list, you'll hear about it as soon as it's open. So I mean, I just spread the word on social media, Facebook, Instagram, TikTok, like whatever, even email. I think that would be great.
But um, and say I had a question a little bit about, you mentioned talking about the caregiver and mental health and sort of how you know, how would we sort of track progress on that, like with caregivers participating in the study, and that sort of thing?
Yeah, so I want to keep asking the same questions moving forward in each annual survey, and then we can kind of see if there are any particular trends. It's only been 2 years that we've been able to ask that, so it's really hard to see if there's any particular elements driving that. Based off of other studies that I've seen, it looks like for both patients and caregivers that early diagnosis time frame is really stressful in terms of mental health. It's just kind of that big unknown. So that might be a good time to kind of come in and help provide some more emotional support services. And then, moving forward, like maybe once there's a certain threshold where it's kind of part of their daily life for like 5 or 10 years, like maybe that's when people start to get a little bit more stressed out as well. So just right now, we probably just need more data, more numbers, and just kind of seeing where that goes moving forward.
Yeah, it's an important area, so we're tracking that. Did you notice any notable geographic or even demographic differences in the responses?
No, it's been pretty constant for the past 3 years. Last year or in 2023, we started to offer the survey in other languages beyond English. And so we did see some uptick outside of the US. This year, especially, we saw a number of respondents in Spain, which is great because that they haven't usually responded to the prior surveys. So we're kind of getting more of a broader general perspective as to what the amyloidosis community looks like at large.
Okay. So sort of what's the next step for translating some of the patient-defined treatment goals into actual clinical trials, kind of putting that into practice?
So at least for me, that will be putting these insights into the peer-reviewed publications. So actually probably tomorrow I'll start on my next abstract based off of the 2024 data and what the trends that we're seeing. And so I think once we start getting more of those publications and building that body of evidence, then that will start being incorporated into some of the newer trials as they're starting to be developed and designed.
Great. I had someone asking, do you have a more granular breakdown of the age of the respondents, including age at diagnosis? So I didn't know if you had that, something that specific.
We do. So just bear with me for a moment. So I'm just going to report out what we saw from the most
Okay.
recent survey because that's pretty generalizable to what we've seen previously. So for AL patients, the average age at diagnosis was 62, and 61 for hereditary and 74 for wild type. In terms of the breakdown of the age, like most of the patients are like between 50 and 65.
Okay. Someone else had asked, they said the lack of access to multidisciplinary medical teams is a significant problem we hear about. And are there any questions that you could include to gain more information on the impact of not seeing doctors in other fields when they are needed?
That's yeah. Yeah, it's hard to kind of measure like the impact of not getting something per se, and what that impact might be. I think if we looked more at like specific outcomes, like maybe other comorbidities or like adverse events and kind of track that more over time, we could be able to see an impact as to what it might look like. But that's something that I'll definitely have to think more about.
Okay,
And is a good point. And
great.
obviously something that we'd want to be able to address.
Okay. Always adding to the to the survey, Sabrina. Um, just curious about you mentioned some action items there at the end. So how do you plan to measure the impact of those action items?
Well, I mean, this survey in general, is one way to at least assess how, that delay, from symptom onset to diagnosis and how that's been changing over time. And like we are seeing some change, and I think as we move forward, hopefully we'll see more and more where it's not years, maybe it's a year or, hopefully even sooner. But that unfortunately is going to take time. And so maybe in a few years we'll be able to see some of the impacts.
Great, thank you. I'm check here to see. Someone is asking if you're using AI or intend to use AI to analyze any survey results and improve the survey as time passes.
Um, yes. Yes. Like, so AI is good and it's also not so good. And so some of it might be is about how well like me or anyone else is able to use it. So some of it's based off of like um user error, I guess.
Mhm.
But it's definitely something like it's a useful tool, and I do think that like moving forward it's going to be incorporated more and more. As to like specifically what we have planned, like there isn't anything directly on paper yet, but it is something that should and probably will be happening.
Great. Are there any particular subtypes, Sabrina, that you feel need more immediate follow-up on some of the things that you learned, or?
I think like some of the slower moving ones, like AL, there has always been this like immediate push. Like once you're diagnosed, you need to start on treatment. Like it needs to be approached very quickly, and that's why there's been a lot of research and drug development around that, as well as any of the cardiac and even neuropathy for TTR amyloidosis. So like ALEX2 is pretty slow moving, and I know in 2023 we had quite a few patients with ALEX2 respond to the survey, and you could really feel like their frustrations with kind of like no options in terms of treatment and like symptom relief. And I think just getting more and more voice to those like ALEC2 or the other ones that impact more of the body. Like we just need more data, and we need more out there to kind of push the needle forward.
Great. So somebody's asking about, how ARC is using this data, obviously, but is this data used by other people, by like researchers or healthcare professionals? And if so, how is that done?
So right now it's just me and ARC. We are open to collaborating moving forward, but right now, and based off of the way the consents for the research was, like it's only intended to be used by ARC, and then any sort of aggregate data. So like the summaries that I provided here, like could be shared, but not like the individual data itself. So moving forward, we might consider different avenues as to how we can collaborate with other researchers moving forward. But right now, it's just mostly staying in-house at ARC, or it is staying in-house in my house specifically.
So somebody's asking, and I think you've mentioned this before because you talked about people who participate from Spain and some other areas, but they're just wondering, is this data available worldwide? Can people participate if they live in other countries? Because this particular individual lives in Mexico and was just wondering about being able to participate just because their treatment options are different and limited.
Yes, yes, and yes. And we will be giving, if they want to provide their responses in English or in Spanish, we'll be offering that moving forward. So yes, yes, and yes, please.
Great. And someone else asked, and I don't know if you have this information, Sabrina, or not, but it was saying the Hispanic group, the ATTR variant group is very interesting. And do you know what variant was most prevalent? I don't know if that's something you have access to, or we could follow up later.
Yeah, I think we need to follow up later with that.
Okay, so we will definitely do that. And then, of course, someone else just followed up with, is the scientific community interested in your data? So let's meet, yes, and that. So, all right. Are there, and we did have a comment, I think, from Isabel, who said data does stay with ARC, but our findings are shared widely and have influenced education around diagnosis as well. So, well, I don't think at this time we have any other questions. Sabrina, is there anything else you'd like to follow up with, or just kind of let people know I know you may have mentioned when the next survey may be coming out?
No, I just want to thank everyone again for participating in both this webinar, and if you've taken the survey before, I appreciate that very much. And so as I mentioned earlier, we are going to have a summary similar to what we've done for the 2022 and 2023 survey available on our website probably later this fall, probably around the same time that we'll launch the 2025 survey. So September, October. So stay tuned for that.
Great. And also, just again, wanted to remind everybody that this presentation was recorded. So I know there was a lot of data, a lot of information. You can kind of go back again and look at that information. And the slides will be on our site as well. So you can kind of take a look more at that. And then you will also get a survey that will pop up after the end of the webinar. We'd appreciate it if you just take an opportunity to fill that out, because that helps us plan for future ARC talks. We hope you'll join us in June. Jan Griffin, who is at MUSC, will be talking about cardiac amyloidosis. So we look forward to seeing you all back again in June. Thank you and have a great rest of your afternoon. Thanks,
Thank you.
Sabrina.